Good morning, everyone. I'm Robin Shapiro, the board chair of HealthAdvocateX, and today we're going to celebrate and acknowledge Indigenous Peoples Day. So we pause to acknowledge that we sit on the land here in Seattle of the Coast Salish, Duwamish, Muckleshoot, Stillaguamish, and Squamish land. We remember their continued connection to the region and give thanks to them for allowing us to live, work, and learn on their traditional land. We offer respect to their elders and to all their people, past and present. Thanks for joining us today, and thank you to Dr. Dale Reisner, who is board member and also medical director at Swedish Health Services in OBGYN Quality and Safety. There's a lot to digest this week, and we prepped yesterday, and there's just a mixed bag that Dale is going to lead us through. And I just want to pause also to say thank you to Dale and all of the healthcare workers that are really facing unprecedented times. And Dale's been very generous in sharing her time and her wisdom with us. So with that, I'll turn it over to Dale.
Sure, and thank you for that, Robin. Yeah, I think thanks is to everybody who is working in healthcare right now, and I'll talk about that a little bit as we go through the things that we'll talk. I'm going to try to do a little bit on a bunch of different things and lots of opportunities for Q&A if that comes up. And Robin, as always, is such a great moderator. She'll be watching the chat box for me. But starting with the traditional data, I'm not going to spend a lot of time with that, but we are globally greater than 237 million cases of COVID and greater than 4.8 million deaths. So a huge impact. And then in the United States, we're now over 44 million cases. We're the highest new case country in the world. And we have over 700,000 deaths in the United States. And a couple of poignant things is, although most of the states are doing well in decreasing numbers of cases per day, and we've certainly seen this in Washington in a pretty wonderful way. There are 5 states that are not, that are still on the increase. And those are Montana, Colorado, Minnesota, Michigan, and Pennsylvania. And I'll talk about vaccinations a little bit, but the bulk of the US, the average is about 56% vaccinated, and most of those states I just mentioned are lower than the US average. So there's a pretty good correlation between degree of vaccination and rates of new cases and deaths. The thing that I wanted to highlight is that there's about 4 medical conditions that are responsible for the majority of the deaths and the ICU admissions, the really sick hospital long stays. And they're hypertension, underlying heart disease, diabetes, and obesity. And often there's more than one thing in a person. When they have one of these comorbidities, they may have more than one. And obviously that makes matters worse. But the thing that's really sad and interesting, really, when you think about immunosuppression, is that obesity is the one state that crosses all ages. So everything else is greater as you get older, kind of makes sense. But the complications we're seeing in young people often are tied with obesity. And that also goes for my specialty area, pregnancy. The really sick patients that we have seen in the last month, I think every one of them had a high BMI, some higher than others, and were unvaccinated. So, even in the vaccinated population, we know we started with boosters that were for people that are immunosuppressed. And we know that at all ages, if you have a condition, and I typically think of immunosuppressed as an autoimmune disorder, but in fact, the leading suppressing diseases and kind of your body's on fire all the time with these are diabetes, hypertension, and cardiovascular disease and obesity. So something about obesity that modulates your immune response. And there's certainly lots we know about pregnancy being immunosuppressed to begin with, as part of why we're able to carry a pregnancy to term, since, part of that fetus, at least half of that fetus is from a foreign agent, right? So, since we like hanging on to our babies as long as we can, close to term, we appreciate being a little immunosuppressed. So I think that's really important to remember as we talk about some of these other things. I know there's a lot of swirl about what monoclonal antibodies, who gets them, who's prioritized, all of that. I'm not going to go too much into that, but I think if we put these parameters kind of, or the background, set it along with some of these other factors of people getting really sick, it might be helpful. The other thing that really hit me, and actually I'm really a wimp, and so I cry, but I was almost in tears when I saw this. Over 140,000 kids in the United States have lost a caregiver, a parent or a grandparent who takes care of them every day.
Wow, I didn't realize that.
That is hard. That's 1 in every 500 children in the United States. And no surprise, ethnic and minority groups have been hit the hardest. And so that is like heartbreaking to me. There's like no way you can ever make up for that. And that has long-term, even disease implications for those children. So it really puts it into perspective of how this disease toll is going to be around for a long time. And we haven't even talked about the other, we've talked about it in past meetings, but the unintended consequences of COVID, how it's impacted the healthcare workforce, the virtual visits, the hesitancy of people, even when there is care available, to go in because they're worried they might be exposed. All of those things where people are not getting screening done in timely fashion and so on. I wanted to talk just a teeny bit about vaccinations. There's actually on the CDC website is kind of a neat graph of when vaccinations first came out and the huge peak there was in the early part of the year and into June. It tapered down a little bit, and then it was like flat and low all through the summer. And in September, we had an increase. It wasn't as big as what I was hoping, because I was hoping that some of the people that were vaccine hesitant would be more comfortable when the FDA gave final approval. And so we did see a bump there. We'll have a continued bump because of mandates. And you can agree or not agree with mandates, but it is increasing our vaccination rate in some people that were hesitant. In most places where there's a mandate, there is the ability to apply for either a medical or deeply held religious objections to vaccination. And we will be seeing the effects of these mandatory vaccinations across the country in various different ways. So we know, for instance, at Swedish, in our labor and delivery population, we're going to lose a rare person, which is great because we are short-staffed to begin with. And there have been, the people had ample time to put in their exemption requests. And also we made it really easy for them to get the Johnson & Johnson vaccine if they hadn't done the others, so that they would meet our state mandates. So we have a state mandate for all healthcare workers and other groups, teachers and so on, to be vaccinated. Where there are going to be other impacts that we haven't talked about is if you look at the military and law enforcement, there's a lot of people that are refusing to vaccinate. And whether they will be held, like we are not letting people work if they're not vaccinated or have exemptions. If they have exemptions, of course, they have to have appropriate PPE. We don't have any kind of formal testing process that we are going to do at this point in time. We'll see how it goes. But I'm not sure how that's going to work when it comes to law enforcement and the military, and what they're going to allow and what exceptions they're going to, back up, they're going to set up. Mm-hmm. Clearly, that's a huge societal impact for both of those groups. Most of the teachers' unions are on board with it. They want their teachers working. They don't want their schools shut. We've seen a couple of schools have to get shut down by outbreaks. But I think our protective folks are, that's a potential concern for me, and should be for all of us. The average I already mentioned is about 56% vaccination rate across the country. However, you guys probably all know that there's pockets where it's really good and other places where it's not. There are counties where it's really like 80%. There's some tiny places where it's 100% and some where it's very low. So part of it is dependent on where you live, just like we have those 5 states that still are having increased cases. So if you think you want to travel, I would say check the CDC first before you decide where you want to go for vacation, or if you have family members or whatever. The overwhelming way people are getting sick is hanging out with friends and family. It really is. It's not healthcare encounters. It's, and things like ball games and, where you look on the
large events.
Huge events, and you see nobody's got a mask on and you're all yelling. And so, that's a great way to spread an easily infectious virus. Mm-hmm. So for protecting yourselves and your clients, I would say still try to do social distancing, mask, don't go places that you don't have to. If you have somebody coming in, so I've had work done in my house and I make everybody be vaccinated and wear a mask when they're in my home. So just be extra cautious, because none of us want to get this virus. And we'll talk about why in a minute. So the other population that's behind on vaccinations is the pregnant population. And there's a couple reasons for that. None of the initial trials for the vaccines were done on pregnant women. That's usually the case. They don't do pregnant women. They don't do children to start with. There were some people who were pregnant at the time, and they have had no first trimester exposures typically, and they've had no increased miscarriage rates, no fetal anomalies, no nothing. We wouldn't have expected, based on the way the virus is made, that it would be a problem. And it took a while for recommendations to be fairly strong about getting vaccinated in pregnancy. We started with most of the national organizations saying, have a discussion. I think you may have heard me say this on past community conversations, and have it be a shared decision-making issue. This was in the early part of the year. And then we have gotten way more directive because we have been seeing really, really sick pregnant women. They are young. They are often overweight or in the obese category by body mass index. And then they're pregnant. So they have a couple of reasons to be susceptible, and way more ventilated pregnant women, some deaths, which are super sad, some really early deliveries where sometimes the babies don't make it, but done to try to save the mother, all of that kind of stuff. We are seeing way more this time around with this variant, probably because it's so much more infectious. And even if you sort of are trying to be careful. If you mix with anybody or your partner is out, it's very easy for it to come home to you.
So,
So,
and Dale, I had somebody who I just went to brunch with over the weekend whose daughter is not vaccinated because before she got pregnant in the fall of 2020, had COVID. So is that protective? What would you say to somebody who's
in the fall of
pregnant?
2020, well, so there is data that there's protection, right, from having what we call the wild virus. However, we don't know how long it lasts, and we are recommending vaccination for those with COVID. We initially were saying, wait a month or so, and now we're not, I would wait till your symptoms are done. As long as you've got a lot of symptoms, you may be having virus. And so I would definitely recommend vaccination for that person. And it's kind of along the lines of, do you get a booster, right? So the other thing that the CDC is now recommending for pregnancy, and they have pregnancy on the list of immunosuppressed or people that are at risk for breakthrough and being sicker with breakthrough viral infections after vaccination. So yeah, the other awesome thing about getting vaccinated while you're pregnant is that those antibodies will stay around for a while, and you will pass them to the baby, and newborns can't get vaccinated. So, and if you're planning on breastfeeding, the antibodies are clearly available in breast milk. So it's a great way to care for your baby without having the baby have a vaccination. So strongly encouraged for pregnant women. We are making vaccines available for those who are hesitant in the hospital, trying to get them vaccinated before they leave if they're interested in doing that. So trying to make it as convenient as possible. It's hard because if what you have is something that needs to be refrigerated and they're all in multi-dose vials, we don't want to waste anything. So right now with the boosters, it's been good because we've been trying to pull in people who want a booster and also do better coverage of our unvaccinated postpartum.
Can I ask you a question related to that, not in pregnancy, but what you said about and I would imagine for most advocates, the majority of the people that they come into contact with probably aren't pregnant women, but are a wide variety of other people. And we've had a question on community conversations before about people wanting to understand the science or the research behind, if you've already had the wild virus, why should you get the vaccine to kind of address that hesitant population? Can you just review with us one more time kind of what we know, or maybe what is still being studied?
Yeah, I mean, the antibodies that you produce from the infection are great, but we don't know how long they last. And we saw people in early 2020 getting more than one COVID infection, not very far out, within a couple of months. And so we just don't know how long those antibodies last. The vaccinations are meant to be longer acting. And as we saw, whether it was because more people of maturity, of age, got vaccinated early on, but as they were measuring antibodies in serum over time after the full set of vaccination from like Pfizer or Moderna, they were seeing the older population having a drop off in number of antibody or percentage of antibodies that were circulating. And so we don't know if that's because they were in the first batch of people that got vaccinated, or if there's something about us using up antibodies quicker. Doesn't make a lot of sense to me, but it's hard to know. And talking to the infectious disease experts and our infection prevention folks, that it's really unknown whether advanced age means that the antibodies don't stick around as long, or if, it is more related to the timing of when you got vaccinations. But we know that 6 to 8 months now is what they're saying instead of 8 months. So, and we know this with flu vaccines as well, right? So it's not a coronavirus, but it is a virus that is around along, every year, and it changes and mutates and so on. And we know that when we first get vaccinated in the fall, it gets us mostly through the winter, but there are some sort of late winter, early spring cases that pop up. So, so that's pretty typical of most vaccinations. It's the rare vaccination that lasts with us lifelong, right? It's more rare.
And while we're on the subject of vaccination, I know some people are putting some stuff on the chat, so don't worry, we're going to get to your question, but I'm going to go to this one from Carrie Andrews first, which is my 25-year-old daughter had a sore throat for 1 day and had a COVID test done on the 1st of October. The results came back positive on the 7th of October. She's fully vaccinated, completely asymptomatic. She's currently quarantining, but has received wildly different information about how long she needs to do so. She has 2 roommates, both of whom are fully vaccinated as well. What is the current recommendation in this case, i.e., when can she leave her room and go back to work? It's a good specific question.
Very specific question. So
sore throat on the 1st, test came back on the 7th that she was positive, asymptomatic, she's quarantining. Because I know at the beginning, quarantining was like 14 days and then it went down. So is there some current wisdom about how long or far out to quarantine?
Yeah, it's probably 14 days from symptom for her. And that is to be safe, right, for others, because you can't really measure and know whether you're infectious or not. That's the hard part. What we've seen with the super sick patients is a recommendation for 3 weeks.
I haven't heard that.
Yes.
Oh, interesting. Okay.
For our patients that spent time in the ICU, we are having them with isolation precautions for much longer periods of time. And so I think that she may have gotten a 10-day quarantine info from someone. I don't know, but I think, I'm glad she has mild symptoms. And for someone like that who has risk factors, so obesity, pregnancy, any other comorbidities, we really recommend that they try to get monoclonal antibodies at this point in time. And that needs to be done within 10 days of diagnosis or symptoms.
So she's past
that, and she may have none of that. She'll be fine. We hope she'll be just fine. Odds are she will. And so the quarantining is really just on the off chance that she's still infectious to somebody else. And with Delta, we've been more worried, I have to say, than with the first variant.
Right. I remember, I think last month we were talking a bit about masking and how now KN95s and masks with filters is the best, according to, that's what you said last month, I think.
Yep.
Yeah.
And they're not too expensive, but they're disposable. You can't wash them. So yeah.
So you were talking about monoclonal antibodies. So let's walk there for a moment and talk a little bit about the new oral treatment and monoclonal antibodies and how easy that is to get, especially, since I don't really know of anybody recently who's gotten COVID, knock on wood somewhere. How easy is it to get the monoclonal antibody or the oral? Like, how does that even work if you want to have that?
So you need a primary care provider to refer you. That's about it. It is an emergency use authorization from the FDA, just like the vaccines were when they first came out. It dramatically decreases the severity of the disease, your need for hospitalization and death.
So you're talking about the oral?
The monoclonal antibodies.
Monoclonal. Okay.
Monoclonal antibodies, right. The oral's not available yet. Okay. So those are done through either in an infusion center or, I mean, it just needs to be done IV. And so like we were able to get it for one of our pregnant patients and the triage nurses did it. We figured that whole thing out. It's really well laid out because it's emergency use. So there's a lot of monitoring and so on.
So like if somebody tests positive.
And they're high risks. So by age, by size, by any other comorbidities, for sure they should have access to that. We know that there are people that don't fit any of those categories that have gotten them as well. And ideally you would make them available to everyone, but they're, it's expensive and it's not, there's not tons of it around. So those are, you preferentially want the higher risk people to know that they have the ability to get access to that. A young person who's normal size and doesn't have any health conditions is probably going to do fine without it. Yeah. So our pregnant women all pretty much qualify as long as we see them within 10 days of diagnosis. They don't all want it, but yeah. Yeah. And so with the pills, so Merck has put in a request for FDA approval for their oral medication. It will be similar use to what we're doing with the monoclonal antibodies. So it's not a prevention in terms of not getting the disease. It's once you've been diagnosed, how do you ameliorate the symptoms and or the severity of the disease? And so what they have shown in their phase 3 trials, which is what you do right before you're getting ready to do the broader FDA approval stuff, is about a 50% reduction in severity of illness and death. So that's pretty similar, I think, to the rates of the monoclonal antibodies. It might be a touch higher for death reduction. And that means staying out of the hospital, having mild symptoms and so on. It's the Merck product is a tablet every 12 hours. I don't know much about potential side effects or any of that stuff at this point in time. And you take them for 5 days. So we shall see what happens, but I know the committee is getting ready to take a look at it. At the same time, both Pfizer and Roche Pharmaceuticals have an oral form, very similar approach. I don't know if the dosing will be the same, that kind of thing, that they are getting close to bringing forth for FDA to look at as well. And I think they're still undergoing those trials. So it's a super expensive pill from Merck. And I think we'll see how well that works. The problem with super expensive means that rich people get it and the rest of the world doesn't. And
it's not covered. It's not expected to be covered.
Who knows?
Okay.
Who knows? Right. Yeah.
And how does it compare to the expense of the monoclonal antibody?
Well, the biggest expense of the monoclonal antibodies is I think it's about $1,000, and then the time to infuse, which is, I can't remember how long it is. It's not too long, and a little bit of OBS afterwards. So it's, I mean, if it's $700 a pill is what I saw for Merck, that's going to be more expensive than, so they're going to, something will have to get right sized.
Yeah.
That way. Yeah. So we'll see a lot more about this in the news. I'm sure it'll be all over everything.
Yeah, Beth Barnett just posted in the chat that the monoclonal antibody is free in Maryland, no charge to the patient.
Yeah, and I don't think our patients are getting charged. Probably what's happening, and this is the same when you go get your vaccination, is if you have insurance, the pharmacy will bill your insurance for administration fee, but they won't charge you anything, and that's just fine with me because
That's great.
insurance, we should get something out of it, right? So so I think that's basically the same. There may be a facility fee or something like that for the monoclonal antibodies at this point in time. Yeah. Who knows what will happen when they come off of emergency use, all of those things, that becomes different. Yeah.
So we do have a question here from Eileen Mandel. What is your experience with the parents of children 5 through 11 and the vaccine, which should be released by the end of October, beginning of November? Not quite sure what the question is, but so parents of kids that aren't eligible for the vaccine yet.
Yeah, there's some interesting stuff starting to happen with that. Even with older kids, like when one parent wants the kids vaccinated and the other one doesn't, and the courts are getting involved. Wow. And I don't know if these are situations of divorce or if it's just, a mismatch in terms of the couple and how they approach vaccination. So I am imagining this is going to be, you'll see it in the news too. There'll be all kinds of, stories. Obviously it's devastating when anybody dies from COVID, but man, when it's a kid, you just really awful, and so I think the majority of people want their kids in school and want their kids vaccinated so they can be safe in school and not get severe disease and so on. And the other thing we've seen, which I'm going to launch into a little bit now, is long COVID can happen in young people with mild disease, and we don't understand why some people get it and why some people don't. And I'm just going to briefly, for anyone, I think most of you on the call probably know what it is, but most COVID infections are resolved or close to it by about a month out. There's some people who had pneumonia that will have some prolonged shortness of breath, but not severe. And usually people are feeling, like they're gradually getting better. If you have symptoms for longer than 12 weeks, you may have long COVID. And it's a huge range of symptoms. So everything, right? So a really common one, I think about 70% of the cases have extreme fatigue. Sometimes debilitating fatigue, sometimes just they can only do so much, or they have to sleep longer or take a nap. Shortness of breath, very common. Chest pain or tightness is variable. A lot of people with brain fog or memory or significant memory issues. There are people that have insomnia and can't sleep properly. Heart palpitations, those who were sick are probably more likely to get that with this cardiac inflammatory kind of situation. So a bunch of neurologic symptoms like needles and pins, and that may or may not go along with the central nervous system symptoms, joint pain, all the kinds of things you would think with perhaps an autoimmune condition. A chunk of mental health, depression and anxiety, especially anxiety. The depression makes sense, if you're debilitated. I mean, if it's really severe, any kind of disorder can do that. But there seems to be a strong correlation with that. You can get, the ringing in the ears and those kinds of things. Some people have a lot of GI symptoms, sort of intermittent nausea, diarrhea, appetite issues, irrespective of the sensory of loss of taste and smell that people may or may not have to begin with. And then temperatures can be variable and rashes can be variable. So it's a lot of stuff that happens with every day or transient. So it's scary. And each person seems to have a different constellation. And sadly, some people have a lot of these symptoms, all in one person.
Well, and I just want to jump in here and say that hopefully everybody who's on this call is signed up for our conference, November 4th through the 6th. And our live day is Friday the 5th. And our opening speaker is Diana Barent, who is the survivor and founder of Survivor Corps, which is the largest worldwide organization of long COVID patients in the world. There are 170,000 people connected to that organization, and she's going to be talking to us along with a researcher, Natalie Lambert, and a long COVID patient about her experience and journey. And I think for advocates especially, it's really important to understand, because there's, like you said, a whole constellation that's very specific to each individual, how to source and find physicians that will even treat long COVID, because it's really difficult. There's a lot to do there, and not all providers are equipped to do it or want to do it or want to do it even, so.
Yeah, the current recommendations are starting with a primary care provider, sorting things out. They can do the basic things, and then, a specialty care. And I know there are centers being set up looking at this particularly. So it will be really fascinating to hear Diana's talk at the meeting. And the only other thing I was going to mention about long COVID is a fascinating thing when it comes to when we're talking about antibodies and the vaccinations. So there are people that have had long COVID symptoms for like a year post who have gotten vaccinated for COVID, and the long COVID symptoms have gone away.
Oh, really?
And
I didn't hear that.
Yes. Oh, wow. This is new. They're starting to collect this data. And so significant improvement or resolution in about 36% of those vaccinated with long COVID. Now, the downside, because there's always a downside, is about 5% it was worse. So they had worsening. Now, whether it was worse long-term or whether they just had a response immediately afterwards, I don't think we know, because a lot of these folks were hesitant to get vaccinated and there wasn't necessarily a recommendation to do so.
Yeah.
So, but it's fascinating to me that getting vaccinated may actually just knock that virus, it might just say, be gone. And so it's a little bit promising.
Encouraging. A little hopeful.
I know. So I'm really curious to see more, for sure. Because this is early stuff, but I really wanted to share that with a little touch on this topic.
I like that. That's a bit of good news
here. Yeah. A little bit of hope. We got pills coming. We got monoclonal antibodies. We got a drop in cases. Be careful around the holidays. Just be careful. But there's one other thing I really have to talk about, and I talked about it a little bit earlier, and that has to do with healthcare providers and how they're faring. And we have there's an article out in USA Today talking about this very topic of the effects that we have on staffing and people leaving healthcare careers because they just can't do it anymore. And it's a range across the area. So you could imagine emergency departments and ICUs, they saw the worst of the worst, and we might be losing them, or we might be losing, medical surgical providers and nurses. I didn't even realize that we have some physicians that were doing surgical procedures and because they weren't working. Some of them were either furloughed or or went without pay. Now, you don't think that they're going to suffer too much, but like many people in this country, not everybody has a nice little slush fund set aside. And so there, there were examples of family doc who was, baristaing, this kind of
Wow.
stuff. Yeah. And if you are employed and your specialty isn't being utilized, no, that wouldn't make sense necessarily for family medicine, but for some of the other surgical specialties. I know my own dermatology group closed and didn't reopen. A couple of the providers are, working someplace else, and the one that I loved and saw retired. So there's early retirements, and there's people that are just leaving healthcare altogether. And those who are left are burned out. And I know burnout is the thing that we hear way too much of, and probably a lot of us on this call are. And we're going to have a talk about that coming up.
Well, and we are, and Ashley,
Yes.
thank you for putting into the chat the registration link. We actually have Sue McWilliams, who some of you might have heard from. She's out of Arizona School of Nursing, who previously talked about health literacy being the new vital sign. She's actually going to do a session at the conference on moral distress and compassion fatigue in our providers, and why that's so important for advocates and patients to understand is how we get care is dependent on how well we're communicating, and we absolutely have to identify and understand what's happening with our providers and give them a little leeway. On our prep call yesterday, Kristen Tellini, who's board member and she's great with Pinnacle Care, she suggested that, for instance, it might be helpful to ask the charge nurse or the person, how best can I help you communicate so that things go well? And just noting how stressful and how things might be different, even asking those questions might be helpful in getting the care that you want for you or your client or family member.
Yes. And compassion fatigue, it overlaps certainly with burnout, but it may be just by itself. And I think that people don't even know that they're doing it. They're sharper when they respond. And, these are usually very caring people in all different phases of healthcare. It might be in a clinic, might be in the hospital somewhere. And
weren't you telling me that many providers are being required to have mandatory overtime?
We have nursing shortages a lot in the OB arena. So OB is different than the other units. It's the most consistently intense area with admissions and discharges, rapid fire, of anywhere in the hospital. So, the emergency department, even the emergency department has a little lull during a certain time of the day, like after 2 a.m., unless you're a trauma center, and early morning, usually not a lot going on. Labor and delivery doesn't work like that. The intensive care unit also, of course, they get admissions at different times of the day, but it's a much smaller volume than a busy labor and delivery unit. And even a small unit somewhere has limited staff to cover if there's, a whole lot of people that come in at one time, or there's somebody who's really sick. And then because we have people leaving the specialty, those who are left are working so hard, and they're trying to be compassionate, but I think, sometimes it doesn't work because you don't have time to stop and say thank you until maybe the end of the shift or that kind of thing. And so just a little bit of grace, I guess, with if somebody is brusque with you, they shouldn't be overtly rude, but then to maybe try to understand how rough things have been for them. And the other is exactly what Robin mentioned, is like when you have your initial encounter with somebody in the hospital or in a clinic, even just saying, we know this last two years have been really rough. And, I'm here as an advocate, so please let me know what I can do to help with communication, because advocacy is we had bad communication or suboptimal communication in the first place, right? That's why we need advocates. And then now we've got even worse. Sometimes you're talking through a mask. And sometimes it's, may just be that you have to yell more than you used to. So there's a lot to think about with that. And there is a lot of work that's going into how do we help people get out from under that. And so I think you're going to see a lot of information about that. You'll see stories about that with people just leaving the field and so on. Social workers, mental health workers are struggling. Exactly. I see that in the chat from Denise. Yes. And it's every phase of healthcare. It doesn't, pharmacists are stretched. Everybody is stretched. So
yeah, we went to go refill a prescription this past week, and there's one pharmacist, very busy pharmacy. And my husband said, "Are you the only person here?" And they said, "Yeah, can't find anybody who will work in the pharmacy."
Yeah,
it's rough. And so that just triple thank you to Dale, because you just for people who are on this call, Dale, who's very busy and has a lot of different responsibilities in the hospital and in the community, also spends a good amount of time prepping for this call to make sure that she's giving you the most up-to-date information. And so I really appreciate that. And I have felt and heard in your voice and experience how challenging that's been for you and your colleagues. So we're really grateful. And let me go back to the chat, and Ray Drazen says, those people who got Moderna vaccine 6 to 8 months ago are still not eligible for a booster unless they fall into the category of immunosuppressed. So please comment, are Moderna patients still protected without the booster?
There has been a suggestion that the Moderna vaccine might be better protection against the Delta variant in particular. And so I think that's part of why folks are not accessing that in the same way. Just remember that there are, like, if you got hypertension, you're potentially immunosuppressed. I don't think most people with high blood pressure think they're immunosuppressed. So there are conditions where you might want to look into getting that booster. But it's just not clear if the coverage is longer or if it's just better coverage against Delta or whatever, but that's where we're at with it. Yeah. I think that you're just gonna, again, if you're careful about masking, careful about what you do in public. I still think you need to limit, don't be in large gatherings. Use that social distancing as a guideline. And then if you're around close family members and they're all vaccinated, you may have heard on this call before, my daughter-in-law is pregnant. I'm going to be a grandma for the first time in December. And so I'm throwing a baby shower for her, and every person who comes has to have COVID and flu vaccines. So you can do that. You can do that with your own family. You can buy the valid rapid test kits at pharmacies when they're not out. And that's the NAAT or the PCR are the ones that you would want. And the NAAT you can do at home and get an answer quite quickly, and it's valid. So if you feel like you want a gathering of folks that way, remember, if you've had an exposure, the ideal time to test is 3 to 5 days after the exposure. And they say, you may may or may not need to quarantine depending on how close that exposure was. So you can test on day one, but you can't be as confident that, and this is why you hear some people say, oh, I had a test and it was negative, and then, my symptoms got worse and I got tested and I was positive.
That's helpful to hear that again.
Yeah.
And can you just reemphasize, and I'm sure people on the call have heard this, but there is some, I know even my mother wanted to space out the booster and the flu shot. So can
Oh
you,
yeah, get them
can you
together.
address that?
Yeah.
There's
yeah.
no,
There's no, I mean, they each have the potential to give you some side effects.
yeah.
I
It
split
doesn't
mine
matter
out.
doubling
It
up.
doesn't matter. Yeah, you can, and in terms of effectiveness, you can get them both together. So if you prefer to have whatever symptoms you might get, if any, I had my booster, I had not that long ago, and I have had some arm pain that was a little bit worse than the other ones and nothing else. I must be lucky. I don't know. And I'm going to get the flu like in the next day or two. So yeah.
There's also Maggie Pheasant would like to revisit the monoclonal antibody discussion about who decides if an obese person can get the monoclonal antibody. Like, how do you know? How do you advocate basically to get the monoclonal?
Yeah, no, just that alone should be enough to get access to it, assuming that you have it in your community and that there's a place to refer to. So
they're not restricting. Like, I call up my primary care and say I've tested positive and I'm BMI of X. Can I get a referral? And that happens quickly.
It should, yes, because you need to do it within it doesn't have to be that day. Sometimes it takes a while to get an appointment, that kind of thing. And so you don't have to worry about that so much. But yes, so if you have that or any of the other, comorbidities that I mentioned, they're trying to think if there's anything else. There's a lot of people fit in to the potential candidates for getting it.
Yeah. Beth, it sounded like you were trying to get a word in here.
No, I was just going to make sure and mention, because I've been helping with vaccines and most people think they can't get both vaccines at the same time, but you can. So I just want to make sure everybody knew that as advocates, to encourage your clients to get both.
Yeah.
And make sure that everybody is flu vaxxed this season, since we didn't see any last year, right?
Yes. Yeah. And we haven't seen a lot of it at this point, but there are some real concerns about, how it may hit us this year. So.
So I have a question. It feels like, and we were talking about this yesterday or earlier this week, it feels like things have calmed down, except for those 5 states that you mentioned in terms. So do we think that it's petering out? Do we expect an uptick over the holidays? Like, what are people thinking? What are the hospital systems thinking about in terms of the next 3 months or so?
It's definitely decreasing in Washington State. Hospitals who put anything that was non-urgent surgically back on hold are going back now to bringing more folks in who need it. It's not as low as we've seen in the last year. So it's on a downward trend. And we really don't know. This is why I keep saying mask and social distance, because Thanksgiving's coming and then there's going to be Christmas. And you saw what happened last year after, first of the year, we had a big boost. Now, with more people vaccinated, we might be great, or we might see small increases, but we just don't know. So,
because we didn't talk about this in prep, but so this is kind of a new thinking question. The data that's coming out of Israel that had a very high overall vaccination rate, they did see an uptick also in virus with Delta variant. But I haven't been kind of following them. I know they've been studying like their vaccination history versus the EU and Canada, which had a longer,
Yes.
wider time between first and second dose. So
Mhm.
do we have any data, updates on that?
I don't think that we have enough information
Mhm.
for that. What the United Kingdom and Canada did was try to get as many people with the first dose.
Mhm.
And then sometimes the second dose was 2 months later, and that might be great.
Mhm.
I don't
Yeah.
think we have enough information. We know we've seen extra cases of the Delta virus in Canada. But
Extra cases of
I mean,
Delta.
the post-vaccination Delta, and the
Oh,
non-vac,
breakthrough. The
yeah,
the
breakthrough, and the
okay. Oh, okay.
non-vaccinated, yes. So,
Huh.
but whether the percentage of breakthrough is different, I think we just probably don't have enough information. I've not seen anything looking at that yet.
Yeah. Maggie Pheasant asked another question. Do you have to test positive before you can request the monoclonal antibody?
Mhm.
Yeah. Okay. So we have about 5 more minutes. So if anybody has any remaining questions, or Dale, I don't know if you have additional thoughts. I'm just kind of looking over.
Yeah, no, I think that a lot of the things, the long COVID and the compassion fatigue that we'll cover in much better depth in the conference will be great. We'll have some talks on race, ethnicity. I talked about the bigger impact on the parents and grandparents of the kids that have Black and brown skin. And we know that in healthcare, there's lots of biases, implicit biases that affect outcomes. That's not just based on race, ethnicity, but it may be based on gender identity. It's based on, sometimes based on religion. The obesity, there's a whole lot of things that for some reason humans like to pick on other humans. And I really not sure why that is, but it's sort of like trying to boost up your own self by hitting on somebody else. And so there's lots of areas in healthcare that are impacted by bias, and how people feel when they come into medical treatment, whether they feel safe and trust, or whether they're assuming something's going to go wrong. And so it's just perfect for the advocacy community to hear talks on this, frequently, I would say, because you guys can help as well. You can identify subtle things that don't feel right for your client, and you can also speak up. We can learn how to speak up in an appropriate way to say, could you ask it a slightly different way? That kind of thing. So yeah, I think there's a lot to offer there.
Yeah, so we, and for those of you who have peeked at the agenda for our conference, Dale's colleague and first Chief Health Equity Officer at Swedish, Nwando and Yanko, I think is how you say her name, who's a pediatrician, and she's a whole lot of other things. She's going to actually be giving one of the live sessions on Friday, November the 5th. I want to just remind people that the conference is November 4th through the 6th, and it's virtual, but also live. And for the sessions that you're not able to make live, we are recording them and keeping them available for you if you want CEs or just to revisit them for up to 6 months. So no problem if you can't make the whole conference, still sign up. There's 2 huge networking activities in addition to a lot of other ways to meet people. This is really the only fall conference focused on health advocacy and health advocates. So a really nice mix of patients and health advocates. We're cooking up a really great program for you, and I think it'll be a lot of fun. So please sign up. And I also wanted to mention that our next community conversation next November our next month in November. We usually have it the second Monday, but we're moving it to the third Monday because the second Monday is right after the conference, and that'll give us a little more breathing room. So it will not be November 8th, it'll be November 15, and we'll change that on the website here shortly. But thank you again, Dale. Thank you to
Thank
Beth
you,
and
Dale.
Kristen also for
Yeah, of course, of
prep,
course.
and thank you all for showing up, and really appreciate all the contributions that everybody on this call are making. So thanks so much. See you
Bye.
soon.
Have a great day, you guys.
Bye-bye.
Thanks.